You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about pericardial effusion and tamponade. We'll talk about definitions, epidemiology, physiology including interventricular dependence, echo findings, and other imaging and management. We'll end by touching upon several related topics, including pericardial cysts and congenital absence of the pericardium. Let's jump in. The normal pericardium contains about 35 to 50 cc's or milliliters of fluid between the parietal and visceral layers. Acute accumulation of about 250 milliliters of fluid can increase the pericardial fluid pressure enough to elicit tamponade physiology. In a chronic setting, tamponade may not become evident even after over a liter of fluid has accumulated. Trivial pericardial effusion is an effusion that is present in systole. Other publications say that trivial pericardial effusion can be present in systole or diastole as long as it is only a few millimeters in width. Semi-quantitative assessment of pericardial effusion is performed by measuring the largest diastolic echo-free space in different echocardiographic views. 1 centimeter and 2 centimeter is the cutoff for small, moderate, and large pericardial effusion. However, these cutoffs were developed decades ago using M mode only. This is why these linear dimensions do not correlate at all with the size of effusion on MRI or CT. In terms of the etiology of pericardial effusion, 30% is from viral pericarditis or idiopathic, that's exudative. 20% are from malignancy, which is exudative. 15% are from heart failure, that's transudative. 10% are from uremia or CKD, that's exudative. Less than 5% of pericardial effusion are from autoimmune diseases such as lupus, rheumatoid arthritis, or scleroderma, that's exudative. Less than 5% are from post-myocardial infarction, that's exudative. Less than 5% are from tuberculosis, which is exudative in the US, but this percent is much higher in endemic TB regions. Less than 5% is from trauma, which can be hemorrhagic or exudative. Less than 5% is from hypothyroidism, which is transudative. Less than 2% is from radiation, which would be exudative. And less than 1% is chylous, which is from the thoracic duct injury or obstruction following trauma, surgery, or lymphoma. Let's move on to physiology. What is ventricular interdependence? This is a key concept to understand. It refers to the enhanced ventricular interaction, whereby during inspiration, right heart filling increases at the expense of left heart filling, and this reverses with expiration. During normal inspiration, the negative intrathoracic pressure draws more blood into the right heart and also pulls more blood in the pulmonary vasculature. The reduction in blood return to the left heart and consequent reduction in left heart stroke volume and cardiac output is usually minimal, causing a drop that is less than 10 millimeters of mercury of blood pressure on inspiration. Whereas in cardiac tamponade, as negative intrathoracic pressure draws blood into the right heart, as usual, the intraventricular septum bows into the left ventricle because the high pressure in the pericardium prevents the right ventricle from complying in any other direction other than towards the interventricular septum. Meanwhile, the high pericardial pressure does not allow the left ventricle from expanding in any way to maintain an adequate end diastolic volume. So, LV filling is reduced and stroke volume and cardiac output are consequently reduced to an exaggerated degree with a drop in blood pressure that is more than 10 millimeters of mercury on inspiration. Pulsus paradoxus is an exaggeration, a drop more than 12 millimeters of mercury of the normal decrease, which is less than 12 millimeters of mercury, in blood pressure that occurs with inspiration. This exaggerated drop in inspiratory blood pressure can be detected by auscultation of the point of initiation of intermittent carotid cough sounds to the point of transition to continuous carotid cough sounds. Asthma exacerbation can cause positive pulsus paradoxus because there are exaggerated intrathoracic pressure changes with inspiration and expiration, which are transmitted to the circulatory system as the diaphragm moves. Conditions that may mimic the presentation of pulsus paradoxus, false positives, are severe COPD, congestive heart failure, mitral stenosis, pulmonary embolism, severe hypovolemic shock, pregnancy, obesity, and tense ascites. Conditions that may mask the presentation of pulsus paradoxus, i.e. false negatives, are hypotension, pericardial adhesions, aortic regurgitation, atrial septal defects, and RV hypertrophy. So if you have any of these conditions and you don't detect a positive pulsus paradoxus, be suspicious that it may still be an issue, that there may still be tamponade. Do not confuse pulsus paradoxus or electrical alternance with pulsus alternans. Pulsus alternans is an arterial pulse with alternating strong and weak beats, even when the heart rate is constant due to marked left ventricular dysfunction. Pulsus alternans is most easily detectable in the femoral arteries, more so than the brachial, radial, and carotid arteries. It can be palpated or observed with sphygmomanometry by deflating the blood pressure cuff below the systolic level. When present, pulsus alternans can be enhanced by maneuvers that decrease venous return, such as standing upright. Because patients with pulsus alternans generally have markedly reduced ventricular contractile function, an S3 gallop sound is common. Pulsus alternans is usually not accompanied by electrical alternans of the QRS complex in ECG. Instead, electrical alternans is seen in large pericardial effusions. Beck's triad for cardiac tamponade is hypotension, jugular venous distension, and muffled heart sounds. Large effusions tend to circumscribe the heart, but small effusions tend to accumulate posteriorly, external to the LV free wall due to effects of gravity. As intrapericardial pressures and right ventricular diastolic pressures rise towards the level of the LV diastolic pressure, all three pressures equalize, leading to a marked decrease in transmural descending pressures, decreased LV filling, and a fall in stroke volume. Reflex tachycardia and increased vascular tone kick in to keep up cardiac output and blood pressure. However, when compensatory mechanisms can no longer maintain cardiac output, blood pressure falls. Eventually, the sinus tachycardia of tamponade may turn to sinus bradycardia and severe tamponade due to sinoatrial node ischemia and signaling from the cardiac depressor branch of the vagus nerve. Therefore, although sinus tachycardia is very common in cardiac tamponade, sinus bradycardia does not exclude the diagnosis of cardiac tamponade. Pericardial effusion may occur in 5 to 30% in patients with hypothyroidism. In that case, you would see a high TSH level, relative bradycardia, and low QRS voltage on ECG. Now let's focus on echo findings of tamponade. When pericardial pressure exceeds intracardiac pressure for a particular chamber, that chamber will collapse. The collapse will occur in a manner that is dependent on the phase of the cardiac cycle. Because the right side of the heart has much more compliant walls than the left side of the heart, RA collapses much earlier than LA collapse. The RA is the first chamber to give in. The RA collapse typically occurs at the end of ventricular diastole, near the QRS on the ECG, and persists until the point in systole where filling pressures into the RA increase the RA pressure above the pericardial pressure. Brief collapse may occur non-specifically in the absence of tamponade. For tamponade, you need to see the RA collapse take up at least 1/3 of the cardiac cycle. The RV withstands a higher pericardial pressure than RA, but eventually also collapses. For this reason, RV collapse is a less sensitive but more specific sign for tamponade. RV collapse occurs in early diastole, which is when the ventricle is least filled, blood all pumped out during systole and not yet replenished from the RA, and persists until the point in diastole when filling pressures into the RV increase the RV pressure above the pericardial pressure. Note that this sign is less reliable if there is RV hypertrophy, for example from pulmonary hypertension, or if increased RV diastolic pressure occurs from other reasons such as hypervolemia. RA collapse starts in late diastole and continues into systole for a variable period. RA collapse is present if it is collapsed more than 1/3 of the cardiac cycle. RV collapse means that the pericardial pressure has elevated to the point that it is reducing cardiac output by 20%. The RV outflow tract is usually the most collapsible portion of the right ventricle, and as such is the first portion of the RV to experience diastolic collapse when the pericardial pressure rises. Different segments of the right ventricular myocardium may not display the same degree of diastolic collapse, or any at all. RA and RV collapse can be falsely negative if the patient has baseline pulmonary hypertension, pericardial adhesions, or right ventricular hypertrophy. Since RA pressure tends to be lower than LA pressure, LA collapse can withstand a higher pericardial pressure and collapses later than the RA. For this reason, LA collapse is a less sensitive but more specific sign for tamponade than RA collapse. In patients with pre-existing pulmonary hypertension with or without RV hypertrophy, it may be possible for LA collapse to occur in the absence of RA or RV collapse. Rarely, LA or LV collapse can also occur in isolation from regional tamponade after trauma or cardiac surgery. When you do PW Doppler at the mitral valve leaflet tips in A4C, more than 30% respiratophasic variation in mitral inflow and more than 60% respiratophasic variation in tricuspid inflow suggests echocardiographic tamponade physiology. You can't just use the tallest and shortest wave. You have to take the first QRS complex that occurs after the onset of inspiration or the onset of expiration, and then take the first ENA after that QRS. You should first adjust the sweep speed to C1 to 2 respiratory cycles only. Use a sweep speed of about 25 to 33 millimeters per second. That way you can select the appropriate QRS complex and the appropriate ENA. Other signs of tamponade physiology on echo are IVC plethora, that's dilation and inspiratory reduction in diameter less than 50%, diastolic blunting of hepatic vein forward flow, respiratory inflow variation across the tricuspid valve of more than 60%, respiratory inflow variation across the mitral valve of more than 30%, and diastolic collapse of the right atrium, diastolic collapse of the right ventricle, which is the most specific finding for cardiac tamponade, and left-sided chamber collapse. How about expiratory diastolic flow reversal of the hepatic vein? Abnormal hepatic vein venous flow refers to inspiratory systolic predominance of hepatic vein forward flow, or expiratory reduction of hepatic vein forward flow, or reversal of hepatic vein flow during diastole. During apnea, forward flow in the hepatic vein only occurs during ventricular systole, not diastole. During inspiration, systolic flow becomes exaggerated and diastolic flow appears. During expiration, systolic flow is reduced to baseline and diastolic flow becomes reversed. The reversal of hepatic vein diastolic flow occurs exactly at the time the tricuspid inflow is lowest. If there is significant pulmonary hypertension, the right ventricle may not be compressed by significant pericardial effusion, even when such an effusion accumulates in a short period of time, because the pulmonary hypertension is giving so much pressure pushback against the pericardium. For example, if the velocity of a pulmonic insufficiency jet at the end of diastole is 3 meters per second, the gradient between the pulmonary artery and the RV at that point is 36 millimeters mercury. You can see my episode on calculating pulmonary artery pressures for the derivation of that. And this suggests significantly increased pulmonary diastolic pressures and thus pulmonary arterial hypertension that prevents RV's diastolic collapse from happening even though tamponade is happening. In tamponade, because you impair early diastolic filling, your E will be low and your E to A ratio will be less than 0.8. The velocity of the mitral annulus may be reduced in cases of lateral wall myocardial infarction or pericardial constriction, but is neither sensitive nor specific for pericardial tamponade. In personal long axis view, zoom out to visualize the circle that is the cross-section of the descending aorta below the mitral valve and straddling between the LA and LV borders. If the effusion is accumulating anterior to the level of the descending aorta, i.e. closer to the probe compared to the circle that is the descending aorta, then it is a pericardial effusion. If the effusion is accumulating posterior to the level of the descending aorta, further from the probe compared to the circle that is the descending aorta, then it is a pleural effusion. That's how you can differentiate the pleural and pericardial effusion in the personal long axis view. On other imaging, such as chest x-ray, with increasing volumes of pericardial fluid, enlargement of the cardiac silhouette will occur, with smoothing out and loss of the normal cardiac contours, leading to a symmetrically distended Erlenmeyer flash-shaped cardiac shadow. Although this may mimic the generalized dilation that occurs in heart failure, the appearance of the pulmonary hiatal distinguishes between these two conditions. In pericardial effusion, the pericardial sac tends to cover the shadows of the hilar vessels as it is further distended, whereas the chest x-ray and CHF will have abnormally prominent hilar vessels and prominent vascular congestion that are not covered by the shadow of the pericardial sac. In terms of management, pericardiocentesis is for cardiac tamponade, Pericardial window is for pericardial effusion that recurs, such as in cancer, and that would be done by the surgeons instead of the interventionalists. Whereas pericardiectomy is for constrictive pericarditis. It is a stripping procedure of the pericardium. Even though the pericardial effusion may look volume overloaded on physical exam, you should not diurese these patients until after you perform pericardiocentesis because they need the central venous pressure to maintain cardiac filling and pushback against the high pressure coming from the pericardium. That's what we have for pericardial effusion and tamponade. I just want to briefly touch upon related topics, pericardial cysts and congenital absence of the pericardium. Pericardial cysts are benign congenital abnormalities that do not communicate with the blood pool. They are often seen in the pericardial reflections and usually asymptomatic. Pericardial cysts do not communicate with the pericardial space. They are typically located in the right costophrenic angle adjacent to the right atrium. They can also be found in the left costophrenic angle, hilum, or superior mediastinum. It should be a well-circumscribed echolucent space. There should be a lack of flow when you apply PW or color Doppler on a pericardial cyst. Even large pericardial cysts will barely compress the RA and are not hemodynamically significant. Pericardial cysts lack malignant potential, although the examination of tissue is necessary to definitively exclude a neoplasm. Distinguish pericardial cysts from pericardial diverticulae, which are herniations through a parietal defect often seen at the costophrenic angles. Since pericardial diverticulae communicate with pericardial space, they can change in size over a short time period, even with changes in body position and respiration, whereas pericardial cysts will not change in size with relation to body position and respiration. Also distinguish pericardial cysts from a hiatal hernia, which would be expected to be posterior to the left atrium and would have a mixed echolucent and echogenic appearance. Ingestion of a carbonated beverage can confirm the diagnosis of hiatal hernia by demonstrating the moving bubbles within the stomach and the hernia. Now, congenital absence of the pericardium could be complete absence of the entire pericardium, or the left pericardium, which is the most common one, or the right pericardium. In congenital absence of the left pericardium, the RV appears larger because the heart is shifted to the left. When you measure the RV volume, it is actually normal. The heart will appear as an upside-down teardrop shape in A4C. Since the pericardium is missing, the LV and RV can expand and be distorted, looking like the body of an upside-down teardrop. The infralateral wall often appears hyperdynamic, and septal motion is frequently paradoxic. Congenital absence of the pericardium is usually asymptomatic. That's all for the episode in pericardial effusion, cardiac tamponade, pericardial cysts, and congenital absence of the pericardium. In the subsequent episode, we will review inflammatory pericarditis.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.